Hello, everyone, and welcome to another session of the Virtual Global Spine Conference. We are excited as we are entering this new year here in 2025 with more really great educational and sometimes controversial content that has to do with spine surgery and spine imaging and so forth. Today, we are pleased to have one of our faculty, our own virtual spine faculty, Dr. Alexander Mameghani, who is a orthopedic spine surgeon in Switzerland. And he is going to share with us some thoughts on a very common topic, which is classification systems of spine, with a focus on both the TLICS and AOSpine, and which one is better. So he is going to tell us which one is better and which one we should be using. Of course, he has no conflicts of interest since he's from Switzerland, but I will leave that to him to discuss. So welcome, everyone, and thanks for joining us.
Yeah, hello, everybody. Hello, Dr. Bartsch. Hello. From Switzerland, it's very late here. I have to apologize. I'm right coming from the OR. My talk, I introduced it on social media with my first video. I have never done this, but it was it was okay. And I just want to make a warm-up. And you see, this is my alter ego. Hello, Alex.
Yeah, TLICS is super easy. We will win this face-off for sure. TLICS is so easy. Even the cousin of the aunt who has a barber, and the barber can use TLICS score. So easy.
Yeah, it is nice to see that things work nicely. But what about the AOSpine side? What is the year going on?
Come on. AOSpine will win this face-off for sure, because the ingredients of this classification is knowledge, experience, biomechanics, science, academic, proven evidence. Everything is in this AOSpine classification. So we will win this face-off for sure.
TLICS, Dr. TLICS, can you respond, please?
Oh, come on, be honest. The easy score is the TLICS score. You can make a decision, a good decision in the mid of the night, and you can teach your residents and your attendings. And when they tell you, I have a TLICS score from 5, I say, go for surgery then. And it's so super easy. And with the AOSpine, come on, you have to study for 10 years. You have to make a PhD and to understand this letter noodle soup of A3, T2. Come on, this is too complicated.
Yeah, thank you, everybody. This is very insightful. I want to do this a little bit interactive for this session. And please go to menti.com or scan the QR code you can see on the screen. Then it's easy for you to interact. I have some polls, some questions, and just feel free to use the interactive slides. I give you some seconds to log in. I will come back to this slide again, so you can log in later too. You can see above always the nice Menti code, and it's about TLICS or TLICS versus AOSpine. Which one are you using? I want to make it a little bit a case-based discussion. I want to show some cases and then ask you what kind of score do you use to go into decision making, whether it's surgery or whether it's conservative. Again, for those who logged in a little bit later, it's about TLICS versus AOSpine classification, interactive session. Menti.com is for free. Nothing will be saved or stored. It's absolutely anonymous. Don't share your name, and just enjoy the interactive sessions. So my first question is, where do you live? Where do you practice? Can you map on the on the world map I hope it is working, so we can see a little bit where you can. I think it's not working properly. The first question is not working. But maybe here again, check in. I will try to. I see some thumbs up to try to make it interactive. What I want to ask you, this is my wish. Don't let it end in a draw. When we end up with no winner, with a draw, the face-off is. We have to repeat it. So I will continue with the talk, and maybe we will finally have a winner. I don't know whether it's not working or not. Can you just tell me? Oh yes, now the first answers are coming in. Is it AOSpine or TLICS? What are you using? TLICS would be red. If anybody uses TLICS score, would be nice to make this circle a little bit bluish. This was just my first two questions. I just wanted to ask you where you're coming from and what classification system are you using? Yeah, thank you very much. Whoever it is, we are not a socialist society with 100% voting for one. We always need the one voice voting for the minority because we don't know which is better yet. After the session, for sure, we know it. So my agenda from this talk is I show you one warm-up case, and then I will introduce both scores because some residents or med students can learn again how these scores are working and how did we get there? Why do we have two systems that work pretty fine and are heavily used in different parts of the world? And then we will do a comparison of both scores case-based because the Virtual Global Spine Conference is a case-based conference. And then let's have some questions and answers. Finally, we will announce the winner. The first warm-up case is very easy. It's a young woman and she had this transverse process fracture. You see a beautiful spine, but you can easily see here where the arrow is, there is fracture of the TP right here. You can't see anything on the lateral imaging of the X-ray, but on the AP, it's hard to identify anything here. The MRI finally shows where the painful lesion is. It was very hard for us to identify this TP fracture. Patient was in severe pain, although this fracture was very, very low. So my first question to you, without introducing TLICS or AOSpine classification, this very painful transverse process fracture, is this something you treat conservative, or do you take the patient straight to the OR? So the majority quickly answers is conservative. And to be honest, this is just a test of the audience, and you passed the test pretty nice. Usually there's one guy or one colleague who chooses surgery just for fun reason, but I really like that you are honest and you all vote for conservative treatment. So my solution, I always show my solution is conservative, and I didn't do any follow-up imaging. But just to remind you, this patient came with some kind of referred pain, was unable to bear the pain. She need in-hospital pain control treatment, which is really astonishing because of these small fracture. And when we classify it with AOSpine, it's A0. When we use the TLICS score, the score is somewhere near 0. So now I will introduce both scores because they are very, very important in the history of classification in spinal injuries. We can go far, like 50 years backwards and look at the Denise classification, which was published in the 80s, so 40 years old, just to make a statement how long a classification can survive in medicine. Even today, there are colleagues who are talking about the Dennis classification of 3-column injuries. They mention the middle column was injured, or the middle column was not injured. And it's so amazing how long terms and classifications can survive. And this is all about our thoughts. We are working with our brains, and we are discussing cases with words and terms, but a unique terminology, a unique model of the spine, how the spine is built up and how injuries have an impact on the patient's outcome, whether an injury is something that is painful for 6 weeks and then it's gone and forgotten, or whether there's an injury and the life is completely changed forever. We have to use words and models, and this is in our brains as physicians. And so classifications always are a mirror of the time where we use it. So a little bit too long text. The TLICS score, this is a nice summary, classification in brief. Colleagues, you can learn a lot about the history, how 2005 Dr. Vaccaro and colleagues have published the TLICS score. They've had a wish to do something better because the classification systems didn't work properly. Their demands were different, and the classification that was available was not meeting their expectation and the needs. And this is the publication of the TLICS 2005. Alex Vaccaro was the first author, but he was not the only. This was a couple of surgeons, of spine specialists, and they published this paper in Spine, renowned journal at that time, a little bit dominated by ortho, not neurosurgery, but it doesn't matter. So what and how did they do it? They collected the insights of specialists, of experts. This is not a score which was invented by randomized controlled studies. There was no huge numbers of patients which were accessed like we have today the term big data, but this wasn't big data. It was experience and experts, and they came together and exchanged their opinions. And where did they come together? They did come together with AO and AOSpine and other societies like NAS or CNS. But the biggest driver of this classification system was the AO. So before there was another generation. I took this image, this red pack image from US American entertainment history. And the pioneers, when 2005 the score was published, yes, it was very, very experienced pioneers, but they were experts. They weren't those scientists we know from today, those who do randomized controlled trials, who do meta-analysis. They tried out implants, they tried out techniques, and then they continued with what was working, and they left those techniques that didn't work, and this was their style of medicine. It was very successful, and they exchanged. Don't do every mistake which was performed in South Africa or North America or Eastern Europe. Just exchange, and this was the red pack. And now with Vaccaro, there was sorry. Sorry, I have clicked wrong. There was another group, more modern, the movies which were very popular at that time, and this was the next generation. And if you look at the names, they are still there. Dr. Vaccaro is still in the AO, Dr. Felix, you know these names. Now let's have a look into the TLICS score. The authors separated and identified 3 different topics. They said they have an independent predicting value of how the patient is doing in the long run. The first is morphology. The second is the PLC, the posterior ligamentous complex, and the third is the neurological status. So they said when there's a compression situation, then you get 1 point. When there is a intact PLC, you get 0 points. When the patient has an incomplete cord syndrome as a neurological status, they get 3 points. You see, they take these 3 patterns, these 3 types of predictors, which were independent in their point of view, and they counted together the points. When the sum is greater than 4, go for surgery. When the sum is 3 or less, it's conservative. When it's 4, they say this is the gray zone. Then we don't make a decision by the score. We let the surgeon choose whether he goes into the OR or whether he does a conservative approach. So again, because it's very important, the morphology is still very important in TLICS. And it is a little bit unclear how you can learn to group your patient in one of these 4 patterns, like compression, burst, translation, or distraction. Have a look at the warm-up case. How many points does the warm-up case get? Because there's no compression in the TP fracture, there's no burst, at least there's no rotation or translation, and there's no distraction. So how many points does a transverse process point get in TLICS score? This is what I meant with somehow 0. Actually, there is no 0 in the TLICS score, but I think you get me right. The classification was not set up for transverse process fractures. The second important point is the posterior ligamentous complex. What is this? And then you have to see, okay, this is a combination of different anatomical parts of the spine. It is a ligamentous component, like the supraspinous ligament. It is the interspinous ligament. It is the facet joint capsular, and it's the flaval ligament. So these 4 components are the ingredients of the posterior ligamentous complex of the PLC. And it is a little bit hard to identify this on spinal imaging. And you get 2, 3, or 0 points about this. Very nice. It is here to see that the neurological status, 0 for intact neuro, or 2 or 3 points is what the clinical status, how the patient is onset in the emergency room, how many points does he get. Very nice to see that an incomplete cord gets more points than a complete cord. Is a little bit controversial because a complete cord is for me the same point like an incomplete cord injury, but this is just subjective for me. But I want to just highlight this. You can discuss about this. So a little bit to the history, because I like to emphasize that it's very important to see the giants on which shoulders we are standing. And Alex Vaccaro played an important role in developing TLICS and the AOSpine classification. And what was his intention? It was just to make the world a little bit better, to teach better, to talk better, to bring people together in the same terminology. Just think about this. Before the internet was changing the world, people were coming together in courses like here in Switzerland, in Davos, and they were checked only in person, maybe via telephone, but you know, the time delay, the time problem, I'm facing the time problem right now, was a little bit bigger than today in our online society. Just a fun fact. Vaccaro was in his spine fellowship 93. Almost 93 was when Magal published the Magal classification, which was later implemented as the first AO classification. But the Magal classification is not the AOSpine classification we are using and talking about today. And another fun fact is Vaccaro has given us his AOL.com email in the paper. I don't know who remembers AOL. It is AOL left Europe a little bit. So there were a lot of validation and reliability studies of the TLICS. But if you have a look how it was performed, it was always small numbers. Like this study published by the group by themselves. You see, last author is Alex Vaccaro, but also Michael Felix, Marcel Dvorak. You see big names, Charles Fisher, Paul Arnold, Neil Anand, Chris Bono, who's editor of famous journals right now, and was a guest here on the Virtual Global Spine Conference as well. Big names. But how did they do it? Well, it was 28 spine surgeons, 8 neurosurgeons, 20 orthosurgeons, and they reviewed only 56 injury cases. You know? And then they forgot these cases, and they went back to these exact the same cases to classify them again 3 months later. And it was really okay. It was moderate from inter-rater reliability. It was good intra-rater reliability. I don't want to talk a lot about this, but you see it was working properly, not only in practice, in clinical practice, but also from the scientific, from the academic point of view. They did well. They didn't set up a classification and just said it works. They looked whether it works properly or not. And this is a little bit a different approach than it was before. And this is really nice. So I start with just a simple case to be solved with TLICS. This is an 88-year-old female, had a minor fall, a massive back pain, and bilateral radiculopathy. So I just want you to ask whether you can classify this or not. This is a TLICS score. Again, you can look at the morphology and you rate from 1 to 4, whether it's a compression fracture, a burst fracture, a translation, rotation fracture, distraction. I tell you, it is a radiculopathy. It is a nerve root, neuro, and I think we have to give 2 points for the nerve root. I will now continue here. Please, again, for those who joined a little bit later, this is the QR code to interact. The first question is, are you familiar with the TLICS score? Do you use it? I would love to hear from you. Yes, I know what it is, but don't use it. Or yes, I know what it is and I use it. Or did you stop using it because you went over to another one? Or do you know this score not at all and just want me to tell you more about it? So again, thank you for interacting. I appreciate every vote. It's nice to see that people take part in. And yes, many are familiar with TLICS. And some of them are still using it, some not. It is interesting. Nobody stopped using it. Maybe they have fallen in love and will never stop using it. And nobody in the audience says that it's not known to this. So again, this is a simple case. 88 female patient. I show you a video here, and this is the video. Can you judge the PLC on CAT scan? Can you see whether there's a posterior involvement? The posterior involvement, wall involvement, would differ between compression, 1 point, or burst, 2 points. And we have radiographs and CAT scan. And I show you again, can you identify whether there's a posterior wall involvement? Is this a burst fracture or is it just a compression fracture? Is the PLC intact or is the PLC not intact? As I told you before, the neurostatus is 2. So either you end up with 3 or with a 4. Let's have a look. In this case of L4 compression fracture, you can slide a little bit. You want an MRI because no PLC involvement would mean no surgery. Or do you say, oh, come on, it's 3 or 4, it's conservative anyway, why more images? Or would you say, okay, listen, I have enough information. I don't need any MRI. I would just offer an MIS solution like a vertebroplasty because it's an old patient, it's a compression fracture, 88 years old. I would not do any open and would not do any strange stuff. Where are you? Do you want an MRI or do you don't want an MRI? You see, I want an MRI, strongly disagree, or in the mid, or strongly agree. I think it's very important that we know for sure that we are doing a lot of imaging in several countries, like in Switzerland. We have the availability of MRI, but to be honest, we do some over imaging. Yeah, so when it's clear, it is conservative treatment because of all the circumstances, the comorbidities, the age, the wish of the patient, we send them to very expensive imaging, and this is not available all over the world. So do you want an MRI or not? Nice, thank you for participating. Some too say, yeah, I would go for surgery anyway with a vertebroplasty. I don't need an MRI. So this is my solution. I did a cement augmentation, just treatment of osteoporotic spine. This is what I did. TLICS, to be honest, is very prevalent, has been very prevalent in North America. Maybe we have a shift towards AOSpine, and from the disciplinary, it is more often used by neurosurgeons than by orthopedics surgeons. And I think it's because of the history, because the old Mager classification was not looking at the neurology. It was just describing the morphology, A, B, C. This was very famous, and this is the AO style. Even if you look to extremities, like a femur shaft fracture, there's an A, B, C. Neurosurgeons don't know these the same way as orthosurgeons know these, because in their education, the focus is much more on the neurosystem, and in the AO, the focus is much more on osteosynthesis. I mean, this is in the name of AO, it's Osteosynthesefragen. So weaknesses and strengths, yes, it is easy to use. It's really easy to use. You count together some numbers, and then you have a decision making. It's a little bit limited in complex cases, like if you have got 3 vertebrae which are like compression fracture, burst fracture without PLC involvement, then it gets a little bit hard, but this is hard for any classification system. Now we're switching to the AOSpine classification, and I guess this is again a little bit of control. Do you know it? Do you use it? Do you know it but you don't use it? Did you stop using it because it's too complicated, or do you want to hear more about it? Because the next slides are about the AOSpine classification. Yes, I think it is congruent with the first question. What are you using? Are you using AOSpine or TLICS? So I will proceed to the next slides, and now we have a look to the AOTL classification. So the AOSpine classification of today is also first described by the group surrounding Alex Vaccaro or led by Alex Vaccaro. And if you want to hear why he introduced him, it's really good if you listen to himself. This video on the AOSpine injury classification's website is very, very insightful. It's not too long, like several minutes, but now you understand why the AOSpine group went over the books and redesigned the classification and summed everything up. This AOSpine classification includes an algorithm. And to be honest, it's very hard for beginners to understand this algorithm when there is nobody who explains this algorithm to you. And this is psychology, it is very hard for experienced surgeons who think that the AOSpine classification from now is the same as the Mameghani classification, which was published 10 or 12 years before the AOSpine classification, which was very complicated and which was very detailed and only useful for academic purposes. So this is the algorithm, and I will explain it to you. The algorithm starts not with the easiest, but with the most severe type of injury. So not the light ones like a TP fracture or a cranial compression fracture. No, it starts to rule out whether there is a displacement or dislocation. You only need one eye to see whether the spine is displaced or dislocated. Yeah, everybody knows a malignon. Everybody knows from when the spine is torn into two fragments. So if there is no C displacement, can you hear me?
Yes, we can hear you. Thank you.
Okay, sorry. I was a little bit confused. So there it's very easy. So when there is no C injury, you test the next step whether there is a B injury. The B injury has got 3 types. And again, you start whether the anterior or the posterior is injured. If the anterior is injured, like here, you can see here, then it's a B3, it's a hyperextension, it's a B3. If it's posteriorly injured, like here or here, it's either a B2 or a B1. And the easy thing is that the B1 fracture is the Chance fracture. The Chance, Dr. Chance was a radiologist in Australia who introduced the term seat belt fracture. And so the seat belt fracture or the Chance fracture is a synonym, eponym. This is the B1, the pure transosseous tension band disruption. And if it's not one of these types, it must be an A fracture. And then you go from A4, whether it's complete, upper and lower end plate, posterior and anterior wall are involved, then it's A4. If it's only incomplete, like the lower part of the vertebra is not injured, but the upper one, or inverse, the upper one is not injured, but the lower one, then it's an incomplete burst. Always note here is the posterior involvement important. When there's no posterior wall involvement, it can be a split, like a pincer fracture, or just a wedge compression in anterior cranial compression fracture or a caudal compression fracture. And if the vertebral body is not involved at all, if it's just the spinous process or a TP, then it's A0. And this is the TP fracture from the start, from the warm-up case. It's A0. We can find this kind of injury in the AOSpine classification. So there is an easy arrow, rule out C, rule out B, look whether it's an A fracture. And if it's not C, if it's not B, if it's not A, you have successfully fulfilled a spinal clearance, there is no injury. Checking and excluding C, then B, then A4, A3, etc., etc. This makes you feel more and more comfortable because the risk for the patient declines from step to step. You first rule out the really severe injuries, and then later you're coming more and more to those types of injuries that can be easily treated conservative. And you can stop very, very easy at C or B and call the spine surgeon if you're in emergency medicine, if you're an emergency physician, because then you don't have to go more and more. Again, it's a little bit complicated. Neurology and modifiers are included, and the modifier is M1 is very important because M2 gets 0 points. The modifier makes sometimes the difference between conservative and operative, because when the injury, it's indeterminate. Maybe there is, maybe there's no injury of the posterior part, then you can give M1 1 point. But you don't need an MRI, and that's very important. So this is the AOSpine classification. You get points as well. And the algorithm is about this subgrouping in type A, type B, or type C. The neurostatus gets, like the TLICS score, you get some points. And this is very easy. You don't have to learn something new. And then this modifier, I told you, when you're not sure whether it's injured or not, you get 1 point. But you don't need an MRI. This is a little bit different to the TLICS score. So when the sum is greater than 4, surgery. When the sum is 4 or less, conservative. When the 4 is the sum, no problem. 4 is surgery. This is a try. Again,
so
I will publish it on social media.
Check whether it's a displacement or a dislocation. If there's no displacement, you can switch over to the B.
I will publish this video on social media because I'm able to explain it in less than 99 seconds. I don't want to bother you with this video. Just want to tell you this.
Best that you first check whether it's a displacement or a
it's easy. So let's go over to the next case. Now the Faceoff starts, and you tell me what to do with this injury. It's a young woman. She's 18 years old. She was riding a horse. She fell down and sustained this kind of injury. And if anybody is out there who want to take this case and classify it according to AOSpine or TLICS score, just give me a sign, use the chat box. Perhaps Dr. Bartsch can moderate a little bit. Otherwise, I will go over again here. This is the CAT scan. You can see here nicely the fracture. The pedicle is fractured. Actually, there's no real involvement of the vertebral body. Or do you see any burst fracture? Do you see any compression fracture? It's very nice to, this is a very unique case. I've never seen a case like this, and it's perfect for a classification. So, oh, sorry. So this was the case studies. I wanted to go here. So here, this was the case I told you. And now this is a young woman. You can obviously see bilateral pedicle fractures. What do you do? Conservative or surgery? What is your recommendation? Can you say, yes, I take her to the surgery? Or do you say, no, conservative still possible? Or do you say, I'm not sure yet? Okay, 3 are voting for surgery. Nobody votes for conservative. Thank you for participating. I will continue with this video and show you another video, because the patient has no neurology. This is the MRI. And when you count the points, you can easily see this is a B1 or B2 fracture. Mostly like it's a chance fracture like somehow, but not really, because the vertebral body is not torn. From the TLICS classification, it is a little bit difficult, because what kind of injury is it from morphology? Is this a compression fracture? This slight enhancement on the MRI, is this a compression fracture? Or is this a distraction fracture of the mechanism and the posterior part is distracted? And it's not easy. I guess it's not easy. You can discuss a lot. Summary, a chance fracture is very easy decision-making with AOSpine. There's no question. It's far over 4, it's surgery. And with the TLICS, we have a clear tendency towards surgery, but you can somehow decide whether it's 4 or 7 points. I hope you understand me. This is my solution. I did a percutaneous stabilization, and after 1 year, you can see here all the bony structures have healed. This is after implant removal. You can see here some shadows of the screws. Patient is doing very fine. Returned to sports and is really living normal life. Just to remind you, when you miss this kind of fractures, then the patient will very likely go into kyphosis, post-traumatic kyphosis, severe deformity, and a big surgery maybe is necessary. Next case, a little bit more difficult. This is a CAT scan and the X-ray. If you look here, this is L5, L4, L3, L2, and L1 seems to be fractured. You see the loss of the vertebral height. You can see here some irregularity in the anterior wall of the cranial end plate. You can see here a little bit compressed bone. What is this for you? Is this surgery or conservative? Elderly woman, L1 vertebral compression fracture, maybe compression, maybe burst. Is surgery or conservative for you? I showed you the TLICS and the AOSpine score. Can you use the scores by yourself and tell me, is this surgery or conservative? Thank you very much for participating. 4 say that they are not convinced. Wow, this is amazing, because I said, okay, it is only surgery or conservative, and then I put in this third option, and everybody from you're not convinced. Okay, I got it. So let's go back to this case, and you can see here it's a little bit easy, because no matter what kind of classification you are using, it is conservative. It is conservative. So this was, this was the MRI. So I can't go. Can I go back? Yeah, here I'm back. This was the MRI, and you can see only a compression fracture. Maybe some fracture lines are here, but the posterior complex is not injured. So from the TLICS score, you get 1 for compression or 2 from burst. 0 and 0 means 2 points. This is conservative. And from the AOSpine classification, you are either A1 or A3, and this is conservative as well. So vertebral compression fractures, very easy. It's maximum 3 points, it's conservative, and the TLICS maximum 2 points, conservative. So what happened? Follow up 4 weeks later, you see there's a kyphosing, it's a collapse of the vertebra, severe pain. And in osteoporosis, the classifications are weak, because the weak bone doesn't let you predict the clinical outcome with a good reliability. This is completely different to the young bone. And you can see here, although we have done a nice stabilization here, another vertebral compression fracture occurred here, which was not present some weeks before. You can see here, this was November, and this is January. Actually, a very recent case, a patient is doing fine. So very important osteoporosis treatment. Introducing a special classification for osteoporotic fractures makes absolutely sense, but it is very hard to set one up, a good one. Next case, classification. So this is a young man who had a fall and had this kind of injury. I want to just tell you, the patient has no neurology at all. And I just want you, I hope I'm coming here. Yes, this is the young man with an L2 injury, new neurology. What do? Surgery? Do you need an MRI? Or do you go for a conservative treatment? Yeah, okay. So it's very easy. I think even if I show this image to patients who are not surgeons, they most likely say, "Oh, this is really looking bad." But let's classify it. Yeah? You have a B2 type fracture, because here you can see involvement of the posterior part as well. Here it is suspected or injured, but it's most likely not to be intact. And then you end up with a score which easily tells you surgery. So what did I do? I did a classic ORIF with a AO fixateur, and then later the anterior support. It's a straightforward case for me, but it's good to have a classification. So the next case is also a young patient. Patient fell down. Again, zero neurology, and the posterior ligamental complex is intact. So I can't show it to you here on this video, but it's intact. From the AOSpine classification, it's a 4. From the TLICS, it's yes, a burst fracture, but it's 0 point on an MRI, and it's 0 point here. We end up here, although it's a complete burst fracture, we end up here in a number smaller than 3. And this is another young man, L4 injury, also no neurology. What are you doing? 2, 3. Okay, seems to be very easy case. Thank you for the conservative treatment option. 2, want to treat this conservative. So this is really good. Having different kind of opinions, this is what our society needs, and discussions about these. This next case of this problem highlights a little bit our problem. In AOSpine, every burst fracture which is complete goes to surgery. Every. The ones who look like very badly and those who don't like so badly. And in TLICS, you end up, when there's no neurology and it's just a burst fracture without PLC, you end up only with 2 points, and very likely to offer conservative treatment. As a surgeon in Switzerland, and I say it's a complete burst, it's A4, this is my solution. And I just wanted to show this solution because we did something else, but not in the first. We did anterior support with a expandable cage, but then we did implant removal after 1 year. And I want to hear from you. Implant removal 1 year after 360, does it make sense or doesn't it make sense? The patient was not pain-free, still had some pain. And you know the discussion, where does the pain come from? Maybe the implants, maybe the muscles don't work properly. There's irritation. We can make it better from the muscles. So the patient was not asymptomatic, still has had pain. We did a CAT scan, and then we did an implant removal. So thank you very much. No way. The majority says no implant removal. So what happened after this? We did this, and I can tell you, implant removal is not a good idea. Pseudos in the young, if you have a pseudotrosis in the young, this is really hard to treat. You have very unhappy patients. Unlucky situation for you as a surgeon. Once you recommended implant removal, and then you end up in a painful situation, a little bit worse than before. And this just has nothing to do with the classifications, but just a reminder, this is not only an interior problem, these complete burst fractures. You always have some facets, and when there's a pseudo, it's really hard. So I want to ask you, MRI and trauma imaging, always necessary, which means you are supporting a little bit the TLICS philosophy to judge the posterior ligamentous complex, the PLC. You need an MRI. Is this mandatory? Is this some kind of malpractice if you don't do an MRI? Or is this highly overrated, the MRI? You don't need it. You can judge any injury with a CAT scan and radiographs. Or do you say, it's nice to have an MRI, why not? It makes me smarter. I get more information, more data to safely treat the patient. Okay, so the radiologist will be happy to see that their imaging is not overrated. And I think we will all order MRI and trauma. Maybe it's not available. Yeah, if you're having a severe trauma in the night from Saturday to Sunday in a rural part of your country, maybe there's no 24/7 availability of MRI, and you can make a decision by CAT scan if you classifying according to AOSpine. But in TLICS, you have some problems without MRI to identify all injured structures of the PLC. So who is the winner? When we look to the evaluation from the spine, and Dr. Santander commented on my LinkedIn advertisement with this nice paper. Here you see they looked 485 consecutive patients in a single center, and they looked what kind of score works better. And interestingly, both were a little bit different. TLICS was being more conservative, but the predictors were very low coincidence of the predictive system. It was very interesting for me. Maybe this is the reason why in the US, burst fractures and compression fractures are a little bit more conservative, like in Europe. And even in Europe, there are differences. You see very straightforward 360 surgeons. Very many are working, for example, in Germany. I worked in Germany as well for a couple of years, 6 years, and I noticed a big difference between Switzerland and Germany, especially when it comes to 360 solutions. So another survey was a systemic review from Dr. Pitt and Dr. Knight, recently published in, I think it was December, which is superior, AOSpine or TLICS, and they looked for a lot of papers, identified a lot of papers, and then they said AOSpine outperformed TLICS in reliability agreement. They did not require additional MRI imaging, which is nice to know for those colleagues who are not having MRI 24/7. So they can use the AOSpine classification to safely lead the patient into the right decision. So thank you very much for your attention. You can now type in your thoughts, TLICS and AOSpine, and maybe Dr. Bartsch will have a final comment on this Faceoff, on this controversy. Do you use AOSpine? I know you are involved in AOSpine, or are you using still TLICS because TLICS works so nice in the clinic routine? And it's really good to teach your residents and attendings a safe way for your patients through the algorithms.
Yeah, thank you. Thanks, Dr. Mameghani, for this really informative session. Such an important topic, really, that it's important in Europe, it's important in North America, it's really important everywhere. For both neurosurgeons, radiologists, orthopedic surgeons, students, trainees. I mean, I think, you really said it best, and especially as you review those papers at the end, I think it's hard to say one classification system is necessarily superior to the other. I think they give you different information, to be honest with you. I do like the AOSpine classification system. I think it's more comprehensive, it's more descriptive. It just makes more sense to me as somebody who used to like the Denise classification. But I will say that TLICS, however, made us really, all of us, more aware of the significance of the posterior tension band and the injury to the posterior complex. I think that's what I like from the TLICS. It just made us a little bit more aware of the significance of those ligaments and those stabilizing structures. So I think the best thing to do is, with a lot of things, is really to know both, and it's to utilize both to make the best decision for the patient. I really, I know you want a winner, but I don't think you're going to get a winner here. I think the winner is really the clinician who understands the strengths and weaknesses of both and is able to apply them to treat patients. The reality is, for a lot of us in academia, you do need to have a consistent classification system, because that's the only way you'll be able to publish papers. But I can tell you, maybe I am a little bit biased because I interact with many surgeons in the AOSpine world, that seems to continue to be probably the more prevalent system on an international level, with the exception of some maybe smaller pockets, primarily in North America, who like TLICS. So I'm not sure how that answered your question, except for the fact that I think both are important. It's good to know both. It's good to use both. And certainly thank you for those wonderful cases and wonderful discussion.
Yeah, thank you, Dr. Bartsch. Thank you, Ali. I'm looking forward for the future, whether AI is able to detect PLC injuries better than human beings. Maybe then we will have a revival of the TLICS score. It is so, don't let us forget good things. And something new, something that was forgotten. Let's meet again in 10 years when big data processing gives us more information. So
that's exactly
who's
right.
presenting next week? Do you know this?
Yeah, perfect. Thank you so much, Dr. Mameghani. That was a great session. We will be advertising next week's topic and speaker very shortly across the social media platforms. So special thanks to especially those who are staying very late or into the hours of the early morning, like our guest or our speaker, Dr. Mameghani. Hope everyone has a great night, and we'll see everybody next Thursday. Take care.
Thank you, everybody, and thank you for participating. It was really appreciated. Thank you very much.